Good evening, everyone, and it's a pleasure to welcome you all on this a very exciting webinar and overview in the management of breast cancer. We carry the greetings from the capital Delhi. A wonderful evening to everyone. It's a pleasure to welcome and invite Dr. Abhishek Bansal, who is a program convener. Sir is a consultant medical oncologist at SSB Hospital and ESI Medical College, Faridabad. A very exciting topic, an overview in the management of breast cancer. Good evening, Dr. Abhishek, sir. Welcome to you. So we give the floor to you for your welcome and introduction and taking the proceedings further. Over to you, sir.
Good evening to everyone present here. I am Dr. Abhishek Bansal, medical oncologist at SSB Hospital ESIC Faridabad, and I welcome you all who are joining me in today's evening. And today we are going to discuss on the updates on management of breast cancer. So breast cancer, as you all know, is the most common cancer in Indian females and also the leading cause of mortality among all the cancer deaths in India, according to the Globocon 2020 data. And the breast cancer survival rate is continuously increasing because of the recent advances in oncology and availability of newer chemotherapeutic agents and targeted therapy and hormonal therapy. So I think we should be up to date on its management and treatment. And to begin this evening session, I would like to invite Dr. Aparna Dhar. She's HOD Medical Genomics and Genetic Counseling, Fortis Memorial Research Institute and SRL Labs, Delhi. And she's going to speak on the topic role of testing BRCA1 and BRCA2 in breast cancer, circulating tumor DNA dynamics in breast cancer, opportunities and challenges. Over to Dr. Aparna, please.
Right, good evening, everyone. Thank you, organizers, for having me here today. So I am gonna, okay, here you go. Right, so I've been given this pretty large task of, walking you through essentially the molecular landscape of breast cancer and its applications and the application of liquid biopsy in circulating tumor DNA in breast cancer. So without much further ado, let's get started. So as we move forward in precision medicine and metastatic breast cancers, I thought we could take a step back and really ask the question, why is profiling important in advanced or metastatic breast cancer? And we know that, today breast cancer is really not just about BRCA1 and BRCA2. So why do we profile? Now, patients with breast cancer, there is a simplistic way of they're classified. The classification is based on the ERPR, and HER2 status. Triple negative, we know, constitutes for 15% of these cases where chemotherapy is the treatment option, and HR positive constitutes for around 70%. Hormone therapy is the mainstay treatment. And
ma'am, sorry to interrupt. Your slides are not moving. I think you're still on slide 1 or so, because you need to make it full screen.
Oh, it is full screen.
Oh my God.
Okay, hold on. I'm going to stop sharing. Okay, give me 1 second.
So Ankit and Geetika, can you just check again?
Yeah, sure, sir.
Sure, sir.
Now is it okay?
No, ma'am.
Geetika?
As if on my end it shows it's a full thing.
So can you go to slide number 2?
Okay, so this is my first slide. I'm on slide 1, 2. Can you see?
No, ma'am, it's not moving.
Oh, that's very odd.
No, it's not.
Can you please
Okay. What do you want me to do? Repeat again?
Ma'am, make it a full screen first, then go to Zoom and share screen, and then click the full screen mode only.
Yeah, that's exactly what I'm doing.
So now we can see your slide, but you need to make it at full screen.
It's full screen.
Can you please share your PPT, ma'am?
Okay, sure.
Yeah, that will be better. You can share the PPT to us, and then
Okay.
Give me
1 second. I'll just send that across then. It's sent.
Ma'am, you WhatsApp or mail?
I mailed it.
Okay.
Yeah, same email address. Sorry, just 2 seconds.
Still not received, ma'am. Okay, I'll ping you on your personal window on WhatsApp. Please share the PPT.
Okay, sure.
Yeah, ma'am, it's received.
Okay, I've sent it on WhatsApp also.
It's okay, ma'am.
Okay, fine. Thank you.
Now it's visible, everyone.
Geetika, it's not full screen.
Yeah, it's not full screen.
It's a full screen.
No, Geetika.
You want to share your full screen, whole screen, desktop screen, not only PPT.
It's the same error that Aparna ma'am is having.
Now it's visible.
Fine.
Okay. All right. After our first world challenges, let's get back and understand as to why molecular profiling is important in breast cancer patients. So next, please. All right, so we know patients with breast cancer, this is a very simplistic view way that they're classified. They're classified based on the ER/PR and HER2 status. So triple negative constitutes for around 15% of those cases in which chemotherapy is your treatment option, HR positive is 70%, hormone therapy is your mainstay of treatment, and approximately 15% of HER2 positive, where anti-HER2 therapy actually improves significantly the prognostic outcome in both early and advanced settings. Next, please. Well, we've moved beyond these intrinsic subtypes, such as your luminal A, your HER2 positive, and your basal-like subtypes. We're now looking for we're looking for genomic drivers. We're looking for alterations in the PI3K pathway, DNA repair genes, resistance mechanisms in the ER signaling pathway, and those growth factor receptors like FGFR1, FGFR1 amplification. While there's no targeted therapy, but it does tell us as to what line of chemotherapy will work and not work for our patients. So what you're essentially doing is you're potentially, this allows us to have targets that can, help us personalize treatment strategies in patients with breast cancer. Next, please. And the reason why this is, important in patients with metastatic breast cancer is that if you look at the genetic landscape, it's very heterogeneous. And as you can see on this slide, that within each of the subtypes, the HR positive, TNBC, you have a plethora of different somatic mutations that can occur. So if you look at the differences between early and metastatic, you can see at least 9 breast cancer, 9 driver mutations at TP53. ESR1, AKT, which were more frequently mutated in the ER positive metastatic versus early. Metastatic breast cancer patients showed an increase in mutational burden, and there was clonal diversity compared to early breast cancers. If we looked at the triple negative breast cancer patients, they had an increase in the frequency of somatic biallelic loss of function mutations related to homologous recombination repair. Next, please. So I think what we really want to understand, the real question is that if you know the ER/PR HER2 status, can you really look beyond that for these targeted therapies? And the very simple answer is yes, we have these targets coming in clinical practice, and we have a number of diagnostics, companion diagnostics that can help you determine mutations in the PI3K, AKT pathway, as well as those ERK, MAP kinase pathways, etc. Next, please. The poster child for building molecular profiling treatment algorithms has really been lung cancer. So, when we know that there's a number of different mutations have resulted in very poor, complex, sorry, go back, please, which have resulted in very complex algorithms for treatments of patients. So in breast, now, if you look at the tumor biology of triple negative breast cancer patients, we know that they're typically associated with the worst prognostic outcome. And as you can see from this heat map here, patients with triple negative breast cancer, it isn't as simple as we think it is. Even in this group of patients, if we see subtypes in luminal AR, mesenchymal, basal immune suppressed, basal immune activated, and among each of these subtypes, we have different treatment strategies, such as you have your immunotherapy for basal immune activated, you've got PARP inhibitors. For those, with alterations in DNA damage repair pathway, you've got immunotherapy combinations in your basal immune suppressed subtype. And of course, then you've got that anti-androgen therapy in your luminal AR. So really, it's not a very simplistic view. Next, please. So what does the molecular landscape look like for our triple negative breast cancer patients? And if we are to profile, be it advanced or metastatic cases, you could get, number one, an alteration in any one of these pathways, and sometimes multiple pathways. So you can have, we know the DNA damage repair pathway, we know PARP and platinum has a clear role. The Olympiad and the Embraco trials, those Kaplan-Meier curves, if you remember them, they're very beautifully separated and illustrated that patients with a GERMA and BRCA mutation had a good response to a PARP inhibitor. Then we've got those inflamed phenotypes where immunotherapy plays a very good role, be it that those waterfall plots of MSI and MMR, or I think it's the Impassion 130 trial where PD-L1 positive cohort showed an improvement in overall survival, and the Keynote 158 where it comes to tumor mutation burden. Then we know we've got the androgen receptor pathway. If it's positive, we have agents, alterations in the big 3CA pathway. We have studies that show that AKT inhibitors like capivasertib in combination with physician's choice chemotherapy, those patients had a far more better response than those who did not have that, who were not given an AKT inhibitor due to lack of a mutation. And then we've got those, agnostic markers like NTRK, RET. In these cohort of patients, we know the HER2 status can change. So again, important targets. Next, please. If we go on to the HR positive patients, understanding the tumor biology of this disease, I think, has become extremely important. And the reason being, patients do acquire that endocrine resistance in those endocrine sensitive tumors. Their tumors have a very small subclone of ESR1 mutation. They've got ESR1 mutations, they could have defects in the MAP kinase or the MYC pathway. So while ER/PR are potential biomarkers looking at the different pathways, it's becoming important to look at, let's say, those patients who acquire an ESR1 mutation, which means your patient will not respond to aromatase inhibitors, and agents like fulvestrant need to be added. Then you've got your DNA damage repair pathway where PARP inhibitors can work. Then you've got AKT PIK3CA where we know the SOLO1 trials for alpelisib. Again, I know that there's drug toxicity, but again, good results over there. And then you've got those agnostic markers. Next, please. In your heavily pretreated cases, the tumors can acquire a HER2 mutation, and especially in our HR positive cohort. And the phase 2 Summit trial actually gave patients, who had acquired a HER2, HER2 mutant breast cancer cases, a combination neratinib with fulvestrant, which had a clinical benefit of 47% and a PFS of around 5.4 months was reported. Next, please. So this is just a far more personalized approach of how we treat our HR positive patients today. Next, please. So with the flavor of season being PARP inhibitors, I very quickly want to draw your attention to a very important concept called BRCA reversion, and especially in our heavily pretreated cases. And we tend to see this in our breast, ovarian, pancreatic, prostate. I've actually seen it in our clinic, but for today, I'm just going to focus on breast. So this is a phenomenon whereby BRCA alterations have the potential to restore their reading frames and revert to the wild type sequence, or remove an initial deleterious alteration and restore at least partial BRCA function. Essentially, BRCA becomes BRCA wild type, and BRCA2, interestingly, is more susceptible. And this was a lovely case study to illustrate this concept of an ER-positive breast cancer patient with multiple lines of therapy. She underwent a comprehensive genomic panel on her tissue. A BRCA mutation was detected, a BRCA2 in particular. She was started on a PARP inhibitor. She had a PFS of around 8 months. She progressed. Chemotherapy was added. She continued to progress. At this point, we did a liquid biopsy, which actually identified and called out those BRCA reversions. Next, please. And all these, alterations, ESMO has actually come out, with a scale for clinical actionability of molecular targets, specifically in breast cancer. And you can see the level 1, level 2 evidence tends to be in terms of looking for what I had already just spoken about, the HER2 amplifications, the germline BRCA mutation, PIK3CA, those MSI and tract agnostic markers, those ESR1 mutations that you acquire over time, PTEN loss, and AKT mutations. Next, please. So today's topic, essentially, the main question is, what is the role of liquid biopsy, specifically in breast cancer patients? Next, please. So we know heterogeneity, both inter and intratumoral, does cause a problem. And when you're trying to trace these biomarkers in your patients, one way to look at the genomic landscape is through liquid biopsy, where you isolate the ctDNA, which is a circulating tumor DNA. It's essentially the somatic, the tumor DNA, which is being discarded into the bloodstream. That gets isolated and studied. This is not to be confused with circulating tumor cell, which is an intact cell that's circulating in the bloodstream. I'm not going to be talking about it, but there's some really promising work happening there. Next, please. So how does a liquid biopsy actually help us? And one of the key distinguishing factors from tissue biopsy, apart from being non-invasive, where liquid biopsy is such an important tool in our armamentarium, is that it helps you detect 2 types of resistance mechanisms. One is by looking at the linear clonal evolution, which basically involves tumor cells, where you have a temporal evolution, where one dominant clone, you lose the dominant clone, and the less dominant clone becomes dominant over time, which is selected out by therapy. And the second type is branch clonal evolution, where you have a spatial evolution in terms of divergence of different clones that happens, and what you essentially get is a mixture of different cancer cells, resulting in resistance. Next, please. So when we use liquid biopsy, the various aspects of clinical practice, you can use it for screening and recurrence detection. It's in clinical trial status with excellent data emerging, but for today, I'm just going to be focusing on the metastatic realm, where the benefits are far more well-defined, where we're addressing the issue of tumor heterogeneity, you're doing treatment and resistance monitoring, you're helping in tailoring drug treatment, tumor profiling, and enhanced longitudinal modeling. Next, please. Now, one of the key questions we ask ourselves is, what is the clinical utility, the benefit of looking at ctDNA in the metastatic disease versus just, profiling the primary tumor? And this was one of the key objectives of the MIRROR study. They wanted to evaluate the concordance of genomic variants between the primary tissue and ctDNA in patients with metastatic breast cancer. And the authors reported that while there was a 97.2% concordance between the metastatic tumors and the ctDNA, what was interesting is that 13 variants in the metastatic tissue and ctDNA was not present in the primary tumor. In addition to this, there was a higher susceptibility, where liquid biopsy was calling out those resistance mutations versus even metastatic tumor testing. So ctDNA was, a good, reliable partner, especially in a metastatic setting. Next, please. So another very fantastic, it's just a brilliant study was the plasma match trial. And the key objective was to report the response, be it complete or partial, to match therapy. In addition, the secondary objective was to analyze the genomic alteration frequencies agreement, with ddPCR and ctDNA, right, NGS, and the concordance between ctDNA and tissue biopsy. Next, please. So for me, I think what was very important in this study was that there was an overall sensitivity of 93%. Liquid biopsy was not inferior to tissue biopsy. In fact, on the liquid biopsy platform, you had a higher variant calling versus tissue biopsy. But even when we did ddPCR versus ctDNA on NGS, which are two liquid biopsy platforms, ctDNA on NGS was far more superior to ddPCR. You had, there was a higher variant calling out with less false positives on your ctDNA NGS versus ddPCR. Next, please. So another very pertinent question is, could you detect these driver mutations for treatment of resistance mutations early versus tissue? Beautiful case study presented by Dr. Chandralapati from Memorial Sloan Kettering, where on an ER-positive patient, invasive ductal carcinoma, and I like using this particular case study, to kind of prove the point as to why liquid biopsy, especially in these HR-positive patients, is a fantastic tool. So if we look at, let's look at the ESR1 mutation. Now we know, if you remember, I told you earlier that even in those endocrine sensitive, there is a small subclonal endocrine resistance lurking around. So look at this ESR1 mutation in the tumor testing. When they did it in February 2015 on tumor, there was no ESR1 mutation. ESR1 was called out in July 2015. Vis-a-vis, ESR1 was actually called out as early as Feb 2015 on ctDNA, which hereby proves the point that ctDNA can help call out those resistance mutations early. Next, please.
Can you conclude your talk?
Yeah. Can you go to the next slide, please? I've got just one more slide. Yeah, two more slides. Yeah. So in this study of, no, go back. In this study of 44, go back. No, back, please. Okay, I can't see my slides.
I guess there is some technical issue. Let me connect to her.
Yeah, just from here, I'll very quickly do this. Okay, so in this particular study of 4,400 patients that underwent a liquid biopsy, this was using the Garden 360, the genomic landscape was very similar to what we would see if we did tissue testing, which was, TP53 topping the charts with 55%, you had your ESR1 mutations at 25%, you had those FGFR1 amplifications, which are 15%, and these have become such an important biomarker in our patients. So again, very, very important data. Next, please. I know I don't have time, so I'm very quickly going to go through this next data. Next one, please. Okay, so this was a concordant study, which was on 105 patients, where they looked at liquid biopsy, where they used the Garden 360, and for the tissue biopsy, they used gold standards like Foundation and Tempus, where they saw that the PIK3CA mutation, only 7.6 was called out on tissue biopsy, whereas ctDNA around 11.4%. Similarly, those ESR1 mutations, only 3.8% were detected on tissue biopsy, whereas on liquid biopsy, it was close to 12 to 13%, which kind of echoes the fact that I think for these resistance mutations, it becomes very important to use liquid biopsy. Next, please. Again, over here, molecularly matched ctDNA testing actually had a higher detection and a greater application for molecularly matched therapy, which was 84 in liquid versus 66%. Next one, please. Next, please. So while there are while there are a lot of pros about liquid biopsy, but I think there are certain challenges, and that has more to do with logistics, the way every lab has different criteria. So your bioinformatics software, your clinical validations have to be bang on to ensure the sensitivity and specificity of liquid is equivalent to that on tissue testing. And I know there's an issue with slides, so I'm going to stop right here and thank you for your patient listening.
Thank you, Dr. Aparna, for the wonderful talk. Now, I will like to invite Dr. KM Partha, Senior Consultant and Clinical Lead in the Department of Medical Oncology at Narayana Dharamshila Cancer Hospital, Delhi, and he is going to speak on the topic role of immunotherapy in triple-negative breast cancer. Over to you, sir.
Okay. Thanks for the invitation. Can I share my slides?
Yes, sir, you can.
Yeah, good evening, everybody. It is nice to talk on a very contemporary subject and an evolving field. My topic today is role of immunotherapy in triple-negative breast cancer. We all know that breast cancer is the second commonest cause of cancer-related death in women, and it is the most common cancer in women altogether. And the poor prognosis in triple-negative breast cancer and the drug resistance thereby presents major inhibitions, which are also the current challenges, and it's quite an evolving field. We all know that breast cancer is a very heterogeneous disease, and microarray based technologies have unraveled the molecular underpinning of several characteristics of breast cancer, and the metastatic propensity, histological grade, and different types, and like that. And we just brush upon the negative as a group as such. Then we go to that landmark study of Empower 130. Before that, we all know that breast cancer is broadly divided into there is a molecular classification: luminal A, luminal B, HER2, and TNBC. And these are the, for time's sake, I am skipping those slides. And what about the incidence? Triple negative breast cancer accounts for around 20% of the breast cancers worldwide. And in India, the average minimum age of presentation is 22 years, maximum age of presentation is 75 years. And among 60% of the patients are below 50 years. And you all know that there are, among triple negative, there are 6 or 7 subtypes: mesenchymal, immunomodulatory, basal-like 2, mesenchymal, luminal, androgen receptor, and unclassified. And what about the triple negative as such? They are large tumors at presentation. They are high grade. Most often they are grade 3 or grade 4, and they have got a higher mortality compared to the other subtypes. They are very aggressive and high risk of distant recurrence also there. This is a description of what I already discussed. They have got a higher rate of the distal recurrence, and the mean time for distal recurrence is lower, a decrease in 5-year survival compared to other breast cancer types, and median survival for metastatic TNBC is around 1 year, whereas in HER2 positive patients, we know that it is close to 5 years, and luminals, we know that it is much better. This is what I was talking about. 5-year survival of TNBC stage 3 and 4 put together is only 30%. And as a group, TNBC compares very poorly with the other subtypes. 5-year OS for TNBC is 77%. vis-a-vis 93% for the rest of the group. This is a description already. What is a high unmet need? That is, overall survival is worse. Treatment options are limited because we cannot use HER2 antibodies or hormonal treatment. Recurrent rates are high, and it's a very aggressive heterogeneous disease that needs further segmentation into treatable subtypes. What about the tumor infiltrating lymphocytes? TIL infiltration is very high in TNBC compared to other subtypes. This bar chart is showing that the second block from the from above, it is showing that around 70% of the TNBC patients either have high TIL or intermediate TIL infiltration. And it has got a high, TNBC has got a high mutation rate, estimated to be 13.3x relative to normal cells, and they produce new antigens that induce immune response. This I'm skipping for the time's sake. So the TCGA data, genetic data has demonstrated that higher PD-L1 mRNA expression in breast tissue specimen from patients with TNBC than in patients with non-TNBC. The high expression suggests a potential role for anti-PD-L1 or anti-PD-1 therapy. So how this PD-L1 pathway works? This diagram is very common. Most of the students must have seen this. The release of cancer antigen cells leads to cancer antigen presentation. Then there is a priming and activation. Then there is trafficking of T cells to tumors, infiltration of T cells into tumors, and there is a recognition of the cancer cells by T cells and killing or apoptosis of cancer cells. So the current management of metastatic TNBC, we all know that what is the first line? We can't use hormonals anyway. So the metastatic TNBC first line is taxanes. Then second line can be either eribulin or capecitabine, or a carbotaxol, or a platinum gemcitabine can also be used. And after 2 lines, eribulin or best supportive care, and that is what we were using. Now there are antibody drug conjugates, and like that, first line as well as second lines are getting changed. That we are going to talk about. What about the in the early stage? Early stage, we are giving neoadjuvant chemotherapy these days, because we all know that the improved PCR will increase the DFS and OS. So if there is a residual, then we all know that capecitabine can be used like that. So I'm not going to the details. And recently, immunotherapy has also got approved in the neoadjuvant setup. So to choose between a single agent and combinations, the performance status of the patients, various adverse events and prior chemotherapy regimens, disease burden, and patient preference, they all play a role. And we all know the previous regimens, eribulin, capecitabine, and gemcarbo, they all showed an increased PFS and OS. So now we will go to the second part of this presentation, that is immunotherapy. That is what I want to talk. So Impassion 130 and Keynote 355, these are the landmark studies. So today we will discuss more about Impassion 130. It's a phase 3 study of TNBC, metastatic inoperable locally advanced TNBC, histologically documented, and prior chemotherapy in curative setting is allowed, but there should be a treatment-free survival interval of at least 12 months, and patients should be either ECOG 0 or 1. Any PD-L1 status were included in the ITT population, but they were further on stratified per the PD-L1 status. So IC status. So here SP142 was the PD-L1 modality used. We all know that it measures the IC. The IC score should be at least it is stratified into either more than or equal to 1 or less than 1. The primary endpoints were PFS and OS in the intent to treat, as well as the PD-L1 positive population. And the secondary endpoints were overall response rates, duration of response, and safety. The study arm was Tecentriq, that is atezolizumab, 840 milligram, that was modified because 1200 is the dose for 3 weekly. So here we are, along with the nab-paclitaxel, we are using monthly twice dose, that is day 1 and day 15. So it has been modified. It has been taken as 840 milligram day 1 and day 15. Nab-paclitaxel, the molecule was chosen because it doesn't require any use of steroids. So it was used 100 milligram per meter square day 1, day 8, day 15. And the placebo arm contains nab-paclitaxel and placebo alone. So by this I have already explained, nab-paclitaxel doesn't require any steroid pre-medication. So we all know that concomitant administration of steroids will decrease the efficacy of immunotherapy. And this is the study population, that PFS. There is a hierarchical setup. PFS in intent to treat population and PFS in PD-L1 population. And then the alpha is set up for overall response rate in intent to treat, as well as ORR in PD-L1 positive population. Then overall survival in the intent to treat population and overall survival in the PD-L1 positive population. So this is the study. The study had 95% power for the primary analysis of PFS in intent to treat patients, and 88% power for OS as co-primary endpoint. Around 900 odd patients, 902 to be precise. Big study, Tecentriq and nab-paclitaxel, and placebo and nab-paclitaxel. And during the study in the intent to treat population, around 451 patients on each arm, and survey on study 246 patients, survival on follow-up 182 patients, and on treatment 64 patients, 64 on Tecentriq and 43 on nab-paclitaxel. So it's very well balanced study. You can see that both arms were equivalent, either in the prior taxane, around 51% on each arm. Prior anthracyclines, that is also 54% on each arm. The number of sites, that is important because you can, if you are reading the literature in the Impassion 131, you know that the number of metastasis, higher patients were higher, so that that spoiled the study. It became a negative study. So here, Impassion 130, 0 to 3 metastatic sites were Tecentriq plus nab-paclitaxel around 74%, and more than 4 was around 26%. And the last block, that is PD-L1 positive patients, around 41% in the Tecentriq arm and 41% in the in the placebo arm. See the intent to treat population. This the curves are separating. You can see that 1 year PFS is there is a 1.7 month median PFS benefit in the atezolizumab arm compared to the placebo arm. You can see that around 6 months the curves are getting separated, and at 6 months it is 7.2 months versus 5.5 months, and the number of in the first year PFS, that is also much better in the Tecentriq arm. So the 2-year OS, that is also numerically higher in the Tecentriq arm, but it was not statistically significant. A 3.7 month numerical difference in the median OS was observed in the addition of Tecentriq to nab-paclitaxel, and this was not statistically significant in the first interim analysis. So what about the OS as per the PDL1 status? Here there is a benefit. The hazard ratio is 0.62, and you can see that the numerical benefit, the OS is 25 months in the PDL1 positive versus 18.4 months in the PDL1 positive of with the placebo arm. So there is a numerical benefit of about 6 months in the Tecentriq arm compared to the placebo. Here you can see that to the left of the median PDL1 positive patients, they have got a hazard ratio of 0.64, and compared to PDL1 negative, there is hazard ratio of 0.95, which is not statistically significant. So PFS benefit was primarily seen in PDL1 positive subgroup, but there was no detrimental effect of Tecentriq in the PDL1 negative. And liver metastasis, prior taxane use, PDL1 status were stratification factors in this study. What about the duration response? The duration response is also significant in the Tecentriq and nab-paclitaxel, that is 7.4 months versus 5.6 months. So the number of higher number of CRs are also seen in Tecentriq and nab-paclitaxel arms, and higher responses as well as durable responses were also seen in the Tecentriq arm. What about the adverse side effects? Yeah, the hepatitis rates were balanced. Most of the side effects were balanced. The only thing is that grade 1 and 2 hypothyroidism, that is 17% in the Tecentriq arm compared to 4% in the placebo arm. So the other thing we will be looking for is pneumonitis. That is also not significant with the Tecentriq, which is very much reassuring. What about the most common adverse effects? Here also you are seeing that most common adverse effects are generally similar between the arms, whether it is any grade or grade 3 or 4. The neutropenia as well as fatigue, alopecia, everything is more or less similar in both the study groups. And serious adverse effects in more than 1% in either arm, regardless of attribution. And here we can see that high proportion of patients in the Tecentriq and nab-paclitaxel arm reported slightly higher adverse effects compared to the placebo and nab-paclitaxel, that is 23% versus 18%. No serious adverse effects were reported that had greater than 2% difference between the treatment arms. That means serious adverse effects are rare. And in the second interim analysis that we are just touching upon, here also the separator curves are remaining separated, and 24 months OS rate is 42% in the Tecentriq arm compared to 39% in the placebo arm. What about the PDL1 positive subset? Here it is much more impressive. That is 25 versus 18 months. But when you take the PDL1 negative, it is not different. So PDL1 positive 2-year overall survival is impressive. The topmost curve that is distinctly separated. And this I have already talked about the treatment-related adverse effects, serious adverse effects leading to treatment withdrawal. They are all more or less equivalent on both the arms. And the steroid treatment is slightly more in the immunotherapy arm. That is to be expected, because in such a big study, many of the immune-related side effects will be there and you have to manage them. So what are the key learning points that we have discussed today? Impassion 130 is the first phase 3 study to demonstrate a benefit in the cancer immunotherapy in metastatic NBC. Benefit and risk profile of Tecentriq and nab-paclitaxel supports a change in practice. And there is a clinically meaningful median overall survival benefit of 25 months of 2-year survival in the PDL1 positive population. That graph we already shown. And the PFS is impressive. And the hazard ratio is 0.62. And biomarker testing should be performed as standard at diagnosis of metastatic TNBC to enable patient to benefit from this treatment. We have seen that SP142 Roche Vendana platform IC score is the methodology we have used in this study. And summarize today's presentation, high incidence of TNBC in India. TNBC is associated with a high relapse rate and overall poor prognosis. Treatment options are limited and it's gradually improving. And there is a meaningful 25-month median OS benefit was observed in the PDL1 positive subgroup in the Tecentriq study in the interim analysis. And it is the first phase 3 study to demonstrate a benefit in the cancer immunotherapy and metastatic TNBC. Later on, the keynote 355 study was has also been approved, and FDA approval is there for Keytruda also. That is for there the PDL1 is by the 22C3 platform, DACO platform. That is, but there the PDL1 positivity should be the cutoff limit is 10% or more in the DACO platform. So both the molecules are approved, but here the platform is different, and the platform are not interchangeable. That the students have to remember. The benefit and risk profile of Tecentriq and nab-paclitaxel supports a change in practice in the first-line treatment of metastatic TNBC. And a brief talk about the that withdrawal in America that came to. I'm not going to this slide, but I'll why this has been withdrawn is in US is that the subsequent Empower 131 that used paclitaxel in place of nab-paclitaxel, that was a negative study, but that had much more higher risk patients, and the placebo of that arm of the paclitaxel plus placebo arm in that Empower 131 study performed rather well. So there are some hot discussions happening. In US right now it has been withdrawn, but in Europe as well as in India, it is still a very useful molecule. And we all know that there are not much choices in the treatment of triple negative breast cancer. So it is in the PDL1 positive patients, the OS and PFS are impressive. And if you are using with the Vendana platform and the PDL1 positive patient, that is at least 1% positivity has been chosen as the cutoff point. it's an excellent first line choice. Thanks for listening. This end of the presentation.
Thank you, sir, for the wonderful talk. Now I will invite Dr. Suman S. Karen. She's a consultant medical oncologist at Fortis Memorial Research Institute, Gurgaon, and she's going to speak on the topic role of novel formulation of docetaxel in management of breast cancer.
Sir, 1 second, sir. Yes, sir. Slide has been moved. Thank you.
Thank you, Dr. Abhishek, and thank you organizers for having me. I'll just share my slide. I hope my slides are visible.
Yeah, ma'am. It's visible.
Just give me a minute. So, good evening, everybody. Today, I'll be discussing the role of docetaxel in the management of cancer, and this is an inter-sponsored session. We all know about the role of taxanes in the management of cancer. It's got a widespread use. There are a lot of indications where we use taxanes, and taxanes are known to increase the survival. We know that they even convert cancers from a non-operable to an operable state in neoadjuvant setting. There's good responses in the metastatic setting. We also know that taxanes are associated with a lot of side effects, like peripheral neuropathy, myelosuppression, and skin toxicity as well. And toxicities are usually cumulative and may lead to dose reduction and cessation of therapy. Solvents are usually the main culprit behind the safety and concerns of conventional taxane formulations. For example, we have now the known drugs. We have paclitaxel, we have got docetaxel, and we've got cabazitaxel. Now the solvents are present in all of them. In paclitaxel, it's Trimofor, and docetaxel, it's tween 80, and Cabazi is also tween 50. So because of this presence of solvent, we need to have pre-medications in all the three formulations. Now, hypersensitivity with docetaxel, generally we overcome this by giving pre-medications, and we do reduce the incidence of hypersensitivity reaction with pre-medications. And despite of pre-medication, however, 8 to 13% of the patients do develop reactions. Fatality are reported in about 34% of the cases due to hypersensitivity reaction, and fatalities due to polysorbate 80 can occur even after pre-medication. So it's very important to find different alternatives, because this is a very widespread use drug. Because the frequency of hypersensitivity reactions with docetaxel, despite pre-medications, there was a black box warning that was put into the package insert by the FDA, and this was about in 2020. And of course, ever since then, we have moved on. Also, FDA warned the cancer drug docetaxel causing alcohol intoxication after treatment. So even this was one of the concerns. So pre-medications that we do require, we know that it's a heavy dose of dexamethasone. Dexamethasone is given 8 mg thrice a day for 3 days, because it's not only just the pre-medication for reactions, it's also for the fluid retention that occurs because of docetaxel. So 1 day prior to chemotherapy and continuing it on day 2 and day 3. And what we do recommend along with it is an antihistaminic, which is dexchlorpheniramine and diphenhydramine, or an equivalent antihistaminic, along with dexamino and or an equivalent corticosteroid, and a ranitidine or any other H2 antagonist. So this is all the drugs that the patient needs to take for 3 days when they're on docetaxel, which is conventional docetaxel. The demerits of conventional docetaxel, we already know, is the fact that it has solvents, it causes hypersensitivity reaction, and there is a need for pre-medications. So there was a need of the hour for a newer technology, which was the nano-aqualip technology that was developed. This is a lipid-based platform technology, which is difficult to formulate for polywater soluble drugs. The advantage is a complete aqueous-based system. It's free from organic hazardous solvents like polysorbate 80 and ethanol, and it's nano-sized, about 100 nanometers. Now that we'll see why it is useful. It is, so this is the docetaxel. There is a hydrophobic cover, and then there is a hydrophobic core and a hydrophilic cover, and all the ingredients, they are naturally occurring grass that's generally regarded as safe lipid contents, like the soya phosphatidylcholine and the sodium cholesterol sulfate. There is no need for pre-medication when it's used as a single agent. Now, some of the approved indications for it are, as you can see here, is for the treatment of patients with advanced gastric adenocarcinoma, for induction treatment of patients with inoperable locally advanced squamous cell carcinoma of head and neck. They are also used in hormone refractory metastatic prostate cancer, locally advanced metastatic breast cancer after failure of prior treatment, and in non-small cell lung CM. So these are the indications. You have two suspensions. You've got it at 20 mg, and you've also got it as an 80 mg suspension. So the optimum size, molecular size, is about 100 nanometers. Now, why is the size optimum? Because we know that normally this is how the endothelial junction is. It's narrow. A lot of solvent drugs cannot actually penetrate the narrow endothelial junction. But in a tumor tissue, it has a very leaky vasculature. And because of the size of it, you can see that these molecules are actually able to escape, penetrate out of the endothelium and actually percolate onto the tissue. So this is called as the enhanced permeability and retention effect. The nanoparticles come and then they leak through the endothelial junctions, they go onto the tissue, they attach themselves to the tissue. As you can see here, there is attachment to it, and then they kill these cells. Now, rest of it, where the junctions are tight, there is a passive just movement of it, and it doesn't actually go through those tissue junctions. And the advantages of this is that no or less dose is needed for pre-medications. Actually, ideally, you don't even need pre-medications with steroids, and less incidence of hypersensitivity. Sometimes you don't even see hypersensitivity reactions or any infusion-related reactions like pain, edema, breathlessness, skin reactions. So now let us look at some of the work that is associated and has been published in terms of docetaxel and its efficacy. So this was the registration trial of docetaxel, and this is the original trial. Therapeutic efficacy is a novel formulation compared with taxotere in locally advanced and metastatic breast cancer. And here they looked at locally advanced breast cancer, about 72 patients with the prior failure to chemo. No steroid medications were given in the nanoparticle arm. And you can see that they were compared with taxotere, and primary objective response rate was seen. The response rate was actually higher in the nanoparticle arm, both in terms of CR and PR together, and in terms of PR as well. There were more number of CRs, 4.2% in the nanoparticle arm. Then there was another study which looked into the efficacy and safety of nanosomal docetaxel lipid suspension in sarcomas. This is another indication where you could use this. This was a study. This included so many patients, different kinds of settings, mostly leiomyosarcoma. And you can see there were some CRs, there were some PRs, and there were 2 PDs that were seen in this study. After that, there was an expert opinion by the Indian oncologists. Some of the prominent medical oncologists that you could see their names over here, where which was published in Oncology Letters. They looked into novel formulations of docetaxel, paclitaxel, and doxorubicin in management of metastatic breast cancer. And here there was a panel of 13 oncology experts. They looked into the guidelines, and this was in the 35th ICON, which is held in Mumbai. And they agreed that the novel formulation of docetaxel would add value to the current management of breast cancer. Majority of them actually agreed that the data of this drug seems convincing in respect to safety. And all of them agreed that they preferred, in fact, the use of this drug in diabetics and patients that you would avoid to use steroids, especially in the metastatic setting. So this is another study which was a multicentric retrospective efficacy and safety data in another indication, that is the metastatic castrate-resistant prostate cancer. They compared 2 weekly regimens versus 3 weekly regimens, and Here, the cumulative dose achieved was about 650 mg in the 2 weekly and 500 mg in the 3 weekly. And if you look at the dose intensity, 84% maintained it in the 2 weekly and about 75% maintained it in the 3 weekly. And you can actually look at the response rates. You can see the water plot. There's actually very good responses in patients who develop the nano lipid formulation. Side effects were not too many. As you can see, they were mostly grade 2, grade 3. Some of the 3 weekly again had grade 1 and grade 2 itself, hardly any grade 3 side effects. Now, in another indication, that is the squamous cell of head and neck, we use a lot of docetaxel. This was again a multicentric study, a retrospective study, and this was conducted in mostly the Bhubaneswar hospitals, and of course even Chennai, Tamil Nadu was included. Then there was another study, which was the nanosomal docetaxel lipid suspension in breast cancer, again showed good results. Now this is a study from Srinagar, and they looked again at the efficacy of it in various solid tumors. Again, it was a retrospective study. They found that 56% of the patients out of 69 were evaluable for response. They had various number of cancers. They had like gastric adenocarcinomas and ovarian and non-small cell carcinoma. And they found that the best overall response rates were achieved in 59% of the patients. They had at least 7 patients who had a CR and 26 patients who had a PR. And their disease control rate was about 98%. And no GCSF support was required whenever there was a monotherapy of this drug. So which is quite promising. This was again another study which was published in ASCO 2018, where they looked into the efficacy and tolerability of nanoparticle docetaxel lipid suspension. And here they found that they observed no new toxicities, and there was no acute allergic reactions, no neuropathy. So again, neuropathy is something that we're worried about, especially in diabetic patients or hypertensive patients or patients who have a pre-inclination to get it. There was no neuropathy over 6 months follow-up. So there are a lot of studies for use of docetaxel even in difficult to treat patients. Like for example, in a patient with prostate cancer who had an allergic reaction to conventional docetaxel. So there's a case report of that, efficacy and safety in low-grade 1 cervical cancer. Also, there is data. Someone has also used it in recurrent penile squamous cell carcinoma as in the neoadjuvant setting, followed by curative surgeries. And patients also being used in low cardiac reserve ovarian cancer patient, because we do know that docetaxel causes fluid retention. So sometimes it becomes a little tricky to use in patients with low cardiac reserve. And again, this is in pregnant MBC patient, again, a rare case report. They've used this successfully. So this is a future program which is being developed, future study, global multicentric 3-arm open-label safety study to look at the efficacy and safety of this drug in triple-negative breast cancer with locally advanced or metastatic breast cancer after the failure of prior chemotherapy. I would like to thank you with this slide. Thank you.
Thank you, madam, for the talk. Now I'm going to invite Dr. Shiv Shankar, who is a consultant medical oncologist at Rajiv Gandhi Cancer Institute, Delhi, and he's going to speak on the topic of role of halogen in metastatic breast cancer. Over to you, Dr. Shiv.
Thank you, Dr. Abhishek, for having me here to deliver a talk on role of eribulin in 2 important indications. That is, one is metastatic breast cancer and another L-type sarcomas. First, I'd like to share my slides. Hope my slides are visible and I am audible.
Yes, sir.
Yes.
It's visible.
Thank you once again. And without wasting much of time, I'd like to start with the topic. Today, we'll be discussing the role of eribulin mesylate in metastatic breast cancer as well as liposarcoma. We all know that this is indicated in 2 important indications. That is, one is metastatic breast cancer and soft tissue sarcoma, L-type. And it is the only drug which, when used as a single agent in later lines, which has shown improvement in not only improvement particularly in overall survival. So if you look at the metastatic breast cancer, the use of eribulin has improved the overall survival from 10.6 to 13.2 months with hazard ratio of 0.81. And in advanced liposarcoma, it almost doubled from 8.4 months in dacarbazine arm to 15.6 months with eribulin. So it has shown a significant overall survival benefit in randomized trials across these two indications. So first, let us briefly look at the role of eribulin in the metastatic breast cancer. For that, we have two phase 3 trials. One is EMBRACE, which included 762 locally advanced or metastatic, locally recurrent or metastatic breast cancer patients who have received at least 2 lines of therapy for advanced disease. They were randomized in 2:1 fashion to either eribulin or treatment of physician choice. Among those who are randomized to eribulin arm, they received 1.4 mg per meter square IV 2 to 5 minutes on day 1 and day 8 of 21-day cycle. The primary endpoint of the study was overall survival, and secondary endpoints were PFS, objective response rates, and safety. So that the median overall survival was 13.1 months versus 10.6 months compared to treatment of patient choice. So it has improved overall survival to the tune of 2.5 months with hazard ratio of 0.81 months. Another important study was a study 301, which again looked at the role of eribulin in a locally advanced or metastatic breast cancer who have received less than 3 prior chemotherapy regimens. They were randomized to either eribulin or capecitabine in 1:1 fashion. Again, the dose of eribulin was 1.4 mg per meter square, used day 1, day 8 in 21-day cycle, compared to capecitabine 1250 mg per meter square for day 1 to day 14 every 21-day cycle. Again, the primary endpoint was overall survival as well as PFS. So in this trial, if you look at again, it had a pre-specified subgroup analysis. It included all kinds of patients, HER2 positive, ER positive, as well as triple negative breast cancer, all were included. If you look at the HER2 positive status, eribulin did not show any benefit compared to capecitabine. Rather, it was numerically lower with the eribulin in the HER2 positive patients. However, if you look at the HER2 negative, it has shown a slightly numerically more benefit in the eribulin arm. However, if you go further in ER negative patients, they may be having PR positive, but only ER negative and HER2 negative. In them, again, it has shown a significant benefit to the tune of 4 months from 10.5 to 14.4 months. And if you strictly restrict to triple negative breast cancer, where as we discussed in the previous talks also, the armamentarium for triple negative breast cancer is very limited, unlike in HER2 and ER positive, where we have a many options which has improved survival to the tune of 4 to 5 years. However, in triple negative breast cancer, the armamentarium is very limited, and even the median survival is to the tune of 1 to 2 years. In that subgroup, it has shown that a significant benefit to the tune of 5 months from 9.4 to 14.4 months with the use of eribulin. Very rarely we come across a overall survival benefit to this tune when used in a later line settings, particularly in a triple negative breast cancer. So in this pre-specified subgroup analysis that as we discussed in triple negative breast cancer, the OS benefit was both clinically and as well as statistically, it was significant. The magnitude of benefit was huge to the tune of 5 months, which has improved from 9.4 to 14.4 months with hazard ratio of 0.70. That is 30% less or reduction in the having a mortality event. And in the HER2 negative patients, the magnitude of benefit was small compared to TNBC patients. It was to the tune of 2.4 months. So they concluded that study 301 authors concluded that in HER2 negative breast cancer patients, when eribulin was added in a later line settings, in beyond second line setting, it has shown a OS survival benefit, and the OS overall survival benefit was highest in the triple negative breast cancer subgroup. So another recent publication that looked at the outcome of this eribulin when used in metastatic triple negative breast cancer In this, 252 metastatic triple negative breast cancer patients were included. When it was used in first or second line, the response rate was huge to the tune of 70%. And those patients who received the eribulin in earlier lines, they had a median OS to the tune of 23 months. That what we see with use of IO agents nowadays, it was to the tune of 2 years. When used in third or fourth line, the response rates were to the tune of 48%, with median OS of 14.7 months. So, though this is not a randomized trial, it again shows confirms the data that eribulin is an active agent in the management of triple negative breast cancer. So these were all the data which were looking at the role of single agent of eribulin. Eribulin is also microtubule inhibitor like taxanes. So how does it work if it add to platinum agents like eribulin plus carboplatin? Is it safe? Does it add any benefits? So this is a very small phase 2 study which included 26 female patients. Among them, 46% had a liver metastasis and 61% had a lung metastasis. The primary endpoint was objective response rates. So when used together, it had a objective response rates of 57% with clinical benefit rate of 68%. And toxicity profile was manageable. Only 4 patients experienced grade 3 or grade 4 neutropenia. And after 26 patients, 4 required a dose reduction in eribulin for grade 3 or 4 neutropenia. So otherwise, the safety concern seems to be not easily manageable, and probably in the coming studies will incorporate these combination regimens with eribulin. So how does eribulin in the era of immunotherapy, where to incorporate? Is there any data? This is again another real world setting data which looked at the role of eribulin when used post immunotherapy. In this, they included 91 patients. Among them, 53 received atezolizumab prior to initiation of eribulin and 38 received a prior sacituzumab. If we look at the 1 year PFS after use of eribulin, that is to the tune of 62%, means more than 50% of the patients did not have a progression at 1 year. That is very, very promising. And 1 year OS rate is also to the tune of 77%, and 2 year OS rate is to the tune of 53%. This real world retrospective analysis provides evidence on eribulin treatment post IO or antibody drug conjugates. So this has shown more than 50% PFS events at 1 year. This is a meta-analysis which looked at the role of eribulin. Roughly, it included 15,000 patients. If you look at this diamond, it is very well favoring the eribulin. It has shown that with hazard ratio of 0.77, that there is a significant OS benefit when eribulin is used in a triple negative breast cancer patients. So how eribulin works in triple negative cancer patients? As we discussed, one is that it is it binds to different sites apart from the other microtubule inhibitors like vinblastine or paclitaxel. The mechanism of action is different. Eribulin binds to farthest part of the beta subunits. So it does not mean that if they have progressed on paclitaxel, it does not work, as the mechanism of action is different. Apart from anti-microtubule agent, it also acts on other actions like vascular remodeling. It inhibits angiogenesis, and another important property is TGF beta inhibition. By inhibiting TGF beta pathway, it renders tumors less aggressive, and also it inhibits conversion of epithelial to mesenchymal transformation, which is very much essential for these cancerous cells to migrate from one place to another place. So by doing so, it prevents onset of new metastasis. So thereby, probably, though it did not show any PFS benefit, it has shown a OS benefit. Probably this characteristics makes a ideal candidate for OS benefit with eribulin. Apart from that, it also favors an immune microenvironment. It inhibits evasion from immune mechanism by inhibiting PD-1 as well as PD-L1. So apart from the anti-microtubule, it also has these 3 important mechanism of action. By doing so, it improves control of the disease as well as improvement in the overall survival. So what is the role of eribulin in hormone positive or negative breast cancer post CDK4/6 inhibitors? We know that most of the patients do go for CDK4/6 inhibitors. Once they progress on CDK4/6 inhibitors, the prognosis is very grim for hormone receptor positive metastatic breast cancer. This looked at the role of eribulin in such setting. So again, eribulin has shown when used upfront post CDK4/6 inhibitors, it has had a objective response rate of 42%. As we go down the line, the objective response rate reduced from 26 to 17%. So we have a recommendation both from the HOSCO as well as NCCN and ESMO to use eribulin in the management of metastatic breast cancer. So looking at the role of eribulin in the L-type sarcoma, this trial looked at the role of eribulin versus dacarbazine in L-type sarcoma. It included both liposarcoma as well as leiomyosarcoma. A patient should have at least received 2 or more prior lines of therapy for advanced disease of soft tissue sarcoma. It was randomized. It is a randomized trial, phase 3 trial. It randomized patient in 1:1 patient to eribulin versus dacarbazine. If you look at the overall population, in that the eribulin had improved the median OS from 11.5 months in the dacarbazine to 13.5 months with eribulin. In intended group treat population, the progression-free survival were almost similar. But if you look at the as pre-specified, if you look at the subset analysis, that is particularly in the liposarcoma, the benefit was the magnitude of benefit was huge. We all know that the drugs work very rarely in liposarcoma. The response rates are to the tune of 20%. In that highly resistant subcategory of tumor, the median OS was improved from 8.4 months to 15.6 months with the benefit of 7 months OS benefit with the use of eribulin. I think it is the first time which has shown such a benefit in the liposarcoma subgroup of patients. If you look at the various type of liposarcoma, they are the dedifferentiated and pleomorphic, which have derived huge benefit from the eribulin compared to dacarbazine. If you look at the myxoid or round cell sarcoma, eribulin was almost the benefit was to the tune of 4 months, and the curves seems to be overlapping. Probably if you look at this myxoid or round cell, probably trabectedin is a better option compared to eribulin if you use in second choice. However, in dedifferentiated and pleomorphic, eribulin has a very good role. Particularly in pleomorphic, it almost quadrupled the median OS from 6 to 22 months. If you look at the safety profile, eribulin has a manageable toxicity, fatigue, nausea. They are quite expected, particularly when used in later line settings. These are expected to happen. And in microtubule agents, we expect neuropathy. However, neuropathy grade 1, grade 2 were to the tune of 20%. However, grade 3 or grade 4 were almost negligible, 1 to 2%. Apart from that, neutropenia were quite common with eribulin. Roughly around 20% of the patients had a grade 3 and 15% had a grade 4 neutropenia with eribulin. So ESMO again recommends use of eribulin in the soft tissue sarcoma, particularly in the liposarcoma setting, where it has shown 7 months OS benefit. So to conclude my talk, eribulin has been approved for use in second-line metastatic breast cancer. It is indicated for the treatment of adult patients with locally advanced or metastatic breast cancer who have progressed after at least one chemotherapeutic regimen for advanced disease with period therapy. Should have included either they should have received both anthracycline and taxane in either adjuvant or metastatic setting, as well as it is approved for use in liposarcoma post anthracycline based therapy. In both the setting, it has shown a significant OS benefit. With this, I conclude my talk. If there are any questions, we can discuss. Thank you.
Thank you, Dr. Shiva, for the wonderful talk. Next session is by Dr. Vineet Govinda Gupta. He is a senior consultant in medical oncology at Artemis Hospital, Gurgaon. And he's going to speak on the topic of PHESGO clinical data and dual HER2 blockade. Over to you, sir.
Hello. Thank you for the kind introduction. I am not able to share my screen. I think there's some technical issue. Okay, I
Now
can do
you
it.
can share, sir.
Okay. So good evening, everybody, and thank you for the nice introduction. So this is the sponsored session by Roche, and we are going to talk about Phesgo, which is a subcutaneous preparation of trastuzumab and pertuzumab. So just a bit of background. We know that pertuzumab is an important drug in our armamentarium. Definitely, it is not for the treatment of choice for every patient, but in the right setting, it is a good component and important component in several settings. For example, in neoadjuvant setting, that is early breast cancer or locally advanced breast cancer, which is at high risk of recurrence. So we have got the studies like Neosphere, Trafina, and Berenice, which have demonstrated that it leads to a large improvement in the pathological complete remission rate, which correlate to long-term event-free survival. In the adjuvant setting, where we have the affinity study, which shows that it reduces the risk of recurrence or death in high-risk patients, most prominently in node-positive patients. And in the metastatic setting, where we have the data from Cleopatra, which shows the large improvement in long-term overall survival with the addition of pertuzumab to trastuzumab and chemotherapy-based frontline therapy. But based on that, the current protocols have evolved to incorporate this treatment. Patient who have got larger size tumor or node positive tumor nowadays, the paradigm is to start with neoadjuvant therapy, followed by surgery, which is ideally pertuzumab based. And for patient with smaller tumors, we can start with upfront surgery, who in case there is a more advanced disease discovered at the time of pathological assessment, they have the option of taking adjuvant pertuzumab as well. But IV infusion of pertuzumab still has some limitation. One is that it increases the time for preparation and infusion of therapy, and it need more resources. Second, it need a long-term venous catheter. So suppose patient is getting lifelong therapy in metastatic setting, and suppose patient get maybe 2 years or 3 years of the trastuzumab and pertuzumab, then each time they need to have cannulation or utilization of PICC line or port. So they will require a long-term venous access to get this therapy. And some patient, we know we cannot use one arm, which is the site of the tumor, and some patient have got a poor quality venous access, and they are not able to utilize a PICC or port. So they have devised a formulation of combination of pertuzumab and trastuzumab, which is Phesgo, which has got a subcutaneous route of administration to overcome these challenges. So the main magic sauce is recombinant human hyaluronidase, which is basically a enzyme which allows delivery of large drug volume into the subcutaneous space. So it is generally given over 5 to 8 minutes as a subcutaneous injection. So what is the basic mechanism of hyaluronidase is that it basically increases the permeability of the subcutaneous tissue, so that when you give the injection, all the drug is not localized into a small space, which is why normally we cannot give more than 1 milliliter of solution in the subcutaneous space. Due to the expansion of the tissue, you can deliver a large volume of drug into the subcutaneous tissue. So just to explain visually, there is a matrix of hyaluron fibers and collagen fiber, and what hyaluronidase does is it degrades the hyaluron fibers, which increases the capacity of the subcutaneous space, and importantly, it is a reversible process. So once after 1 or 2 days, the architecture of the skin gets formed back again, and by that time the drug is usually cleared enough that it will not lead to a problem. So for example, if you look at a patient who has not got hyaluronidase, you can see that it forms a large bleb if you try to give 10 ml of solution into the subcutaneous space. Well, same is not true if you are giving the hyaluronic acid. So you can see that there is a small swelling, but you don't generally get a bleb or pain or difficulty in injecting into the local site. So there were a number of studies which have been done to look at the new preparation, including the phase 1 study, which was a dose finding study, and the phase 3 studies and phase 2 study, which looked at the equivalence to intravenous formulation from clinical point of view and the physician and patient acceptability. So I will not go into detail of the phase 1 study, but basically they found that a loading dose of 1200 mg per jeta and maintenance dose of 600 mg of pertuzumab is the dose which is recommended for further studies. And the pharmacokinetic data agreed that it achieves the required concentration in the tissues without compromising the safety. So there was a phase 3 study called Frederica, which looked at the non-inferiority between these two IV and subcutaneous preparation. So there was a arm A and arm B. Arm A was AC followed by intravenous Perjeta with paclitaxel or docetaxel and trastuzumab, and arm B was AC followed by subcutaneous fixed dose combination with paclitaxel or docetaxel as per the investigator choice, followed by surgery and followed by continuation treatment with again IV or subcutaneous regimen as per the arm of question. And the primary endpoint was non-inferiority of cycle 7 trough concentration with multiple other pharmacokinetic efficacy and safety endpoints. So just a bit comment of what we mean by trough concentration. So when we give any drug to somebody, whether it is IV, subcutaneous, intramuscular, whatever, you can see that initially, so the dark green line is what is typical for a IV drug, that immediately there is a large concentration of the drug in the blood, which then falls in an exponential manner. So the Cmax is the maximum concentration of the drug, and C trough is the lowest concentration of the drug just before the next dose. So subcutaneous administration has different kinetics as compared to IV administration. Generally, what happens is that the peak concentration appears in the blood a little bit later because the absorption into the blood is slightly delayed. But again, the concentration falls off after that until achieving the trough concentration. And AUC is it is equivalent to an integral of the area under the curve. So basically, it assesses the total product of the time and concentration to figure out the average exposure of the drug. So in this study, when we first while talking about the primary endpoint, they found that the trough concentration was not inferior with subcutaneous formulation. You can see that in the green bar, the trough concentration is superior, or basically it is equivalent to the IV concentration. I will not say superior. So the non-inferiority was successfully proven. If we look at the efficacy endpoint in this study, the pathological CR rate was basically the same between the two formulations. And one question you might ask is, we are giving fixed dose combination. So maybe there is a difference based on the patient body weight. And what they found is that the rate of pathological CR is actually comparable across different body weight classes. In the underweight, the number of patients is very small. So only 3 patients and 7 patients. So that first, I would ask you not to look at the first one, because out of 3 patients, it's very difficult to calculate a percentage, but the other arm were comparable. Safety profile was well comparable. If you look at the rate of grade 3 or higher AE and serious AE, it was comparable to the intravenous formulation. There was 1 death in each arm, and discontinuation rate was lower with subcutaneous treatment. And overall, the type of AE was also well balanced. One important concern you might ask is, what is the rate of drug reaction? So you can see that the rate of drug reaction within 24 hours is slightly higher with subcutaneous formulation, but overall safety appears to be comparable between the two formulation. And cardiac toxicity is the important question when we are using anti-HER2 antibody. And it was shown that the cardiac safety is comparable or lower with the new formulation, therefore establishing the non-inferiority overall as well as in terms of safety with the subcutaneous formulation. So Francisca was a phase 2 study which looked at the acceptability for patient and the doctor for the formulation. So when patients were asked which formulation they preferred, actually patient had the chance to access both formulation, and majority of patients said that they were happier with the subcutaneous formulation, and most of them found that satisfaction rate was much higher with subcutaneous formulation compared to the intravenous formulation. So one more good thing for busy daycare is that it reduces the preparation and administration time to around 25 minutes compared to almost 2 to 3 hours with the intravenous formulation. Therefore, it represents a major amount of time saving. And if we look at the adverse event in Francisca, quite comparable, and no major difference in the safety. The thing is, how do we practically use this drug? I hope by now a lot of oncologists have had exposure to this medicine, and I am quite happy with my experience in the few patients where I've used it so far. So important is that patient should be in a resting position and the leg should be stable. If the leg is moving, then you might cause pain to the patient. So seat the patient comfortably. You can use a blanket to provide privacy to the patient, and you can sit next to the patient at the eye level. The hand should be stable. Again, movement of the hand will cause pain. And it is given in the anterior thigh, which is the main site of therapy. And you should alternate the site of injection. And each injection site should be 1 centimeter from previous injection site. So it is given as a subcutaneous injection at a 30-degree angle. You can pinch the skin to access the subcutaneous space. And the needle is supplied with the injection, which will ensure that the rate of injection is not faster than what is recommended. So the loading dose is given over 8 minutes and the maintenance dose is given over 5 minutes, followed by half an hour and 15 minutes of observation respectively, to make sure patient doesn't suffer any immediate adverse event like drug reaction. And it is generally a good idea to build a single, if there is adequate load of these administrations, it might be a good idea to have an isolated area where subcutaneous injection are delivered so that SOP could be implemented properly. So just to conclude, this regimen offers significant advantages to patient over the IV formulation, a shorter administration time, easier to administer, no need for venous access. The toxicity profile is similar, and cost factor at present is also similar and without any new safety signal, and overall good acceptability for doctor as well as patients. So we'll end with that, and thank you very much for patient listening.
Thank you, sir, for the talk. I think we have half an hour left. We are early, I suppose.
Yes, sir. Can you closing remarks?
So maybe any questions from the audience, if any, to anybody of our speakers or to me? I think there are none.
Yes, sir. We can conclude the session as well.
So thank you all the speakers for their new inputs and on the audience for their attentive listening. It was a great and fruitful discussion on breast cancer, and I think we will incorporate what we learned today in our daily practice. Thank you.